anesthesia. This is one of the main fears of patients who want to undergo plastic surgery. And today I brought a special guest, Dr. Marina, who is our anesthesiologist here at the clinic, so she can demystify all these fears and beliefs, right? All those superstitions that exist around anesthesia. And you will understand why anesthesia is so safe and why we prefer to perform surgeries in a hospital rather than in a clinic. I am Dr. Juni Favarin, plastic surgeon, and this is our Monday live session. Here at the clinic, we prefer to perform our facial surgeries under general anesthesia. We always perform surgeries in a hospital, not a clinic, and we always have the same anesthesia team. Dr. Marina is our official anesthesiologist, and she will explain a little to you how we perform these anesthetics.
Hey.
How are you, Marina?
All. Good night.
You are very welcome. Thank you very much for accepting the invitation to talk a little about anesthesia. With all your experience, right, as someone who works in a large hospital setting, I usually tell patients that having surgery in a hospital is different from having surgery in a clinic, right? We're setting up the clinic, we're going to have a space for sedation, but that's just for comfort. But I wanted your technical opinion on this, right? What would you say is the main difference between operating in a hospital, like San Jose, for example, which is a large hospital, and operating in a clinic?
Yeah, so it's not just the team, right, that makes the difference. But in a hospital, we feel much safer because of all the technological resources and all the staff involved. There's also the matter of having professionals from various fields, several colleagues as well, who can help you in a specific case. We also have access to some technologies that we can't have in a clinic, in addition to having an area with ICU beds, right? A space with an ICU in case something happens. And there's also the matter of monitoring. We can't have all the equipment needed to provide greater safety for the patient in the clinic, especially when compared to a hospital, right? That's why for some procedures, we prefer to do them in the hospital and others in the clinic, right? This will be carefully considered, and each procedure will be properly recommended for a specific location.
Perfect. And I don't know if you notice this with your patients, but I see a lot that they are very afraid of general anesthesia. So let's demystify that, right? Some of these beliefs that patients have. So I'd like you to explain, for example, what's the difference between doing sedation and doing general anesthesia?
All right, let's get into it then. So with sedation, we only have hypnosis. Hypnosis would be removing consciousness. And anesthesia isn't just that, right? General anesthesia is basically made up of 4 pillars, which are hypnosis, which is taking away consciousness so the patient is not aware. We also deal with pain, right? Analgesia. The patient won't feel pain. They can feel pain. Another very important thing is immobility. The patient has to remain still, providing the right surgical conditions, a proper environment for the surgeon to perform the surgery. And also there's the control of the autonomic system. What is the autonomic system? It's blood pressure, heart rate, and some involuntary reflexes the patient might have. So in general anesthesia, this is much more controlled than in sedation. Sedation is something simpler. It basically covers 1 or 2 pillars of anesthesia, right? With that, we could act on immobile, on sedation, right? On hypnosis and also on analgesia, on pain, right? But with general anesthesia, we basically have all 4 pillars. General anesthesia also, unlike sedation, involves intubating the patient, right? The patient is intubated with a device.
That's something patients are afraid of. They're afraid of intubation, maybe because of COVID, right?
Because of COVID, right? No, not at all. And intubation is a procedure that the anesthesiologist performs routinely every day, several times a day. They're the most qualified professional to carry out this kind of procedure. And also at the hospital, we have a video laryngoscope, which is a specific device to help with intubation in case it turns out to be difficult, right? Depending on the evaluation. And we also perform anesthesia in the throat area, so the patient feels less discomfort. And when it's time to extubate, to remove the tube, they don't keep coughing, don't feel that discomfort, and don't have to strain to get the tube out.
And about the monitoring, which is what you just mentioned, right? A lot of people don't notice those little devices that are back there.
One of the fears patients have, right, is they always ask, I think it's a really important question for July, oh, am I going to wake up in the middle of the anesthesia? Am I going to wake up? No, guys, no. The patient does not wake up in the middle of anesthesia, in the middle of surgery. We have a device that it's a little sticker on the forehead, and it can read the waves from the electroencephalogram. And this device does a calculation, and in this calculation, it gives us a number, which is the magic number, from 40 to 60. And that's when we know we're at an adequate depth of anesthesia. If it's above 60, the patient is becoming more superficial. So I still have time to adjust the medications, to give more anesthetic, more drugs to keep the patient asleep. So they don't actually wake up because there's still a pretty big margin before they would wake up. And if the patient is too deep, right, with a very low anesthetic depth, then there are also some risks involved, right? So we have this magic number between 40 and 60 that allows us to see and ensure the patient stays at an appropriate depth.
For those who don't know, this BIS monitor for us surgeons, right, who are on the other side of the drape, it was something magical. Here, I think it's been about 8 years that we've been using it in Criciúma, and I was amazed the first time I saw that little device working. Even today, when Marina puts it on, I find it so interesting to see how calmly the patients wake up. I usually say they wake up just like from a nap at home, because Marina has complete control over the level of sedation depth the patient is at, so she knows exactly when they're going to wake up. It's really interesting. I think it's wonderful.
It's cool. I think, like, look, they're already waking up, guys. I'll call you, and I come over like Juni. Soon the patient is already awake.
And Marina, a lot of people also ask me the opposite. Doctor, is there a risk that I won't wake up from the anesthesia?
No, guys, no. No, there's really no risk. The risk is very, very low, right? In medicine, nothing is ever 100%, right? But the risk is basically it doesn't exist, right? The body has the ability to break down these drugs, remove them from the bloodstream, and we can also use some reversal agents for certain drugs we use. And we end up just waiting for the patient to wake up, right? Each patient will have their own timing, right? Basically, the times are similar, right? But some are faster, others slower. So we just wait for the patient to wake up. It's very calm. There's no problem with not waking up. The patient will definitely wake up.
So I remembered, Marina, a patient we operated on last Thursday, a patient who used, testosterone. We know that testosterone is a hormone, and this particular patient took quite a while to wake up.
He did take a while.
And for us, it's very clear that the metabolism of medications is basically done through the liver. So probably because of the medications this patient was taking before, he had used up some of those liver enzymes, and that's why his metabolism was delayed. So here's one more piece of information for you, right? Anyone who has some kind of liver overload, who takes specific medications, like, for example, testosterone or those hormones for muscle gain, these are patients who have a greater it's not really resistance, but they do take longer to wake up.
That's right, exactly. That's why the pre-anesthetic evaluation is so important, and why you should always tell us which medications you use. Don't hide it, because we need that information to provide safe anesthesia and quality surgery for our patients. In this case, it was expected that he would take a little longer to wake up, so we stayed there waiting until he came around. He took almost twice as long to wake up as a typical patient usually does, right? Twice as long, but we were there waiting, and when it was his time, he woke up and everything was fine.
All good. And Marina, who are the other patients usually, it's usually elderly patients, right, who take longer to metabolize as well, and also Asians, right?
Yes, Asians too, the elderly, and also patients with liver function issues, right? Be careful with cirrhotic patients and also patients with kidney disease, depending on the drug. So all of this highlights the importance of pre-anesthetic preoperative tests, so we can assess these functions as well, right?
Marina, can you explain a little bit to everyone what this pre-anesthetic consultation is? Because sometimes the patient asks, oh, but am I going to talk to the anesthesiologist? Yes, everyone will talk to the anesthesiologist.
That's right. Everyone talks to the anesthesiologist, right? So every patient is referred for a pre-anesthetic consultation, which is usually done during the week or about a week before the surgery. Yeah, it doesn't necessarily have to be the same anesthesiologist who does the pre-anesthetic consultation and the one who will administer the anesthesia on the day of the surgery. And during that consultation, we gather some very important information, right? We collect information about weight, height, current medications, comorbidities, perform an appropriate physical exam, and review the test results. Usually Dr. Juni brings the test results, right? She requests them at the office, and we review them together with her. If necessary, we'll request additional tests as well. And during that time, we also provide information about fasting, answer any questions, clarify things for the patient, and explain how the anesthesia will work, right? A lot of people have never undergone surgery before, so they don't know what to expect. And we also explain about the medications. Some medications need to be stopped beforehand, while others can be continued. So everything is clarified there, which is why the pre-anesthetic consultation is so important.
And another thing that for use and for the patients, I think is very important, Marina, is having this routine that we've managed to establish. So tomorrow we're going to operate on a patient, right? You already know who it is. It's a patient who had an abnormality on her electrocardiogram. We had already reviewed her tests beforehand, and I always share this with Marina. Marina, what do you think? Should I send her to the cardiologist? We have our own criteria, but nothing beats asking the person who will be taking care of the patient during surgery what the best course of action is. And she already had, an echocardiogram that showed everything was fine.
Yes, exactly. We always have this very close communication. Whenever June has a question or when there's a situation that's out of the ordinary, the doctor lets me know and I check it out in advance. If necessary, we refer the patient, and we do the whole evaluation together.
Let me see. Another question, Marina, that everyone asks me, which is safer, general anesthesia or local? Beth even asked this. Can a blepharoplasty be done in a clinic? Yes, it can.
Yes, it can be done. It all depends on the procedure. It also depends on the surgeon's preference, and also the anesthesiologist's preference. A blepharoplasty can definitely be done in a clinic with sedation.
Absolutely.
That's right. However, Dr. June prefers to do it in the hospital's surgical center. I also prefer to do it in the hospital's surgical center with the patient under general anesthesia, because we always joke, right? It's never just a blepharoplasty. Yeah, there's going to be fat harvesting, there's going to be fillers, Dr. June is going to treat the skin. And all of this is safer for both me and Dr. June when done under general anesthesia. We already have this communication and agreement. I prefer it feeling safer, and the patient is safer with general anesthesia at the hospital's surgical center.
Yeah, Marina already gets it. She already knows how it is. We don't even need to say much.
No.
Look, Marina Beth sent the following question. Does the amount of anesthesia depend on a person's weight and height?
It does. It really does. Some drugs,
Is it okay to lie about your weight, guys?
you can lie about your weight. We need to know your weight, height, and age. Yeah, there's a pump, an infusion pump that, I don't need to administer the medication manually. It does the calculation for me of how much medication needs to be infused as I enter the concentration I want, either in the blood or wherever the medication is supposed to act. So it does the calculation itself, and it bases this calculation on the patient's age, weight, height, and sex. So all of that influences the amount of medication the patient will receive. That's why you can't lie about the data, right?
That's true. Look, Elisangela asked a question I was going to ask you. Doctor, why does anesthesia usually cause nausea and vomiting? That used to be a pretty common thing, right, back in the day?
It's actually quite common, yes. Anesthesia used to be like that, and even today it can still be used. It's not wrong. The anesthesia we use is a bit different, and it's administered intravenously. That means we don't use the anesthetic gas, which is the gas that causes nausea and vomiting. That doesn't happen to all patients, right? Nowadays, the gases already have less of that ability to cause nausea and vomiting, but we use an anesthesia that's only infused through the vein without gas. This provides more comfort for the patient, prevents nausea and vomiting, and also allows for a smoother awakening. And in the past, there used to be much more nausea and vomiting than there is today, right? And we also have other medications available, right, that can be used to prevent post-operative nausea and vomiting. There are some risk factors, right? So if someone has already experienced postoperative nausea and vomiting in the past with another type of surgery, they might have a higher chance of developing it again. So we take all this care, we cover all the mechanisms of action with different medications to prevent this kind of side effect.
Another question that everyone always asks me is about that test to see if you're allergic to the medication. Doctor, but don't I need to take that test to find out if I'm allergic to anesthesia? Talk a little about that, about what anaphylactic shock is, since people are so afraid of it. I think these are things worth discussing.
So anaphylactic shock is a very rare situation. Yes, it's a situation where the person develops a very strong allergy, right, in which there's a lot of release of inflammatory mediators, which causes a drop in blood pressure. In addition to everything else, it's something much more complex than just that, right? But we can tell what it is according to the monitoring, if the patient is having this kind of reaction, so we can act as quickly as possible so the patient has fewer consequences. It's a very rare situation. No, you don't need to do an allergy test. You don't need to do that skin test. We only do that test in very specific situations, right? A patient who has already been anesthetized and developed this kind of reaction, yes, but no, there's no indication to have all patients undergo this test, okay? That's why we always ask the patient. You'll be asked many times if you have any allergies. June will ask during the pre-op consultation, and I'll also ask on the day of the anesthesia, on the day of the surgery. So there's always this checklist that might seem really repetitive, but it's to provide more safety for the patient.
So do you want to say a little about that? I think it's good for us to talk about this for those who have heart conditions, for those who have arrhythmia, for those who have prolapse.
So all these circumstances we assess during the pre-anesthetic evaluation, right, in the pre-anesthetic consultation, and we look at the tests, and depending on the situation, refer the patient to a cardiologist so we can be cleared or not for surgery. Yes, there are all these precautions in the preoperative preparation, right? Regarding medications, and also during the intraoperative period, we're able to pay closer attention, monitoring the monitors, maybe making sure the patient is as safe as possible during this perioperative period, right? That's why the evaluation is so important. We need to know how this person's heart is doing, how the pump is working, if it's functioning well, if the patient will be able to handle surgery, to handle the postoperative period, right? This heart is going to need to, right? Because surgery, as Julie mentioned, is a stressor, right? The body wasn't prepared for this. It's going to experience stress. And anesthesia will help to ease that stress, right? So that the patient stays as physiological, as normal, as natural as possible. That's why the pre-anesthetic evaluation is such an important factor.
Marina, would you like to make any final remarks before we wrap up?
Thank you for the invitation. It's really great to be here talking, explaining, informing, right? A little bit about my specialty, right? And if you have any other questions, want to send them to me. Patients who are having surgery usually receive a message from the anesthesiologist the night before, the day before. If there are still any questions, we're here to answer them. Also, if there's any problem after surgery, you can send a message as well. And if anyone has any questions, you can also message me on Instagram. Okay, I'll be more than happy to answer.
Look, I guarantee that Marina will reply. She's very responsible and super engaged. Marina, thank you again. And tomorrow morning, we'll meet at the operating room. Same bad time, same bad channel.
That's right. Thanks, Julie.
Thank you. Everyone, thank you so much for participating. See you next Monday.